start? Can you see my screen? I'm sharing my screen.
Yes po, Doc.
Okay. Yeah, I think some of you are my preceptorial last year. No, so I'm Dr. Lian Hamisola. No, I'm the training officer of the section of dermatology here in UER. And I'll be discussing the common skin disorders. Okay, so our objectives for this morning, at the end of the lecture, the students should be able to identify the common diseases in dermatology, to differentiate among the common cutaneous diseases based on the major features from the history and physical examination, to come up with an impression together with some differential diagnosis for a dermatologic case, to identify applicable diagnostic tests that may aid in the confirmation of the diagnosis, and to enumerate treatment options and give a management plan for each of the common cutaneous diseases. So these are the common cutaneous diseases that I'll be discussing. We'll start first with endogenous eczemas and then viral skin infection. So you see there's a lot. And then skin infestations, acne and rosacea, contact dermatitis. So ito naman yung exogenous eczemas. Psoriasis, Hansen's disease, pityriasis rosea, urticaria, scabies, and superficial fungal infections. Some are already discussed extensively by Dr. Yang, if I'm not mistaken. So I'll just be brushing through them because they are part of the common cutaneous diseases. Okay, so let's start with eczema. This came from a Greek word meaning boiling out. Okay, so sa US, it's called dermatitis. Sa Europe, it's called eczema. So it has 3 stages: acute, subacute, and chronic. All of these stages will be characterized by pruritus or sobrang makate. These lesions are really itchy. Okay, so the first stage, the acute, what you will see are the lesions are erythematous, edematous, they are weepy, so medyo basa, no? And can have vesicle formation. When they progress to subacute stage, then there comes your secondary skin lesions. If you remember your primary and secondary skin lesions. So for subacute, there will have already crusts and scaling as your secondary skin lesions. And for chronic stage, the secondary skin lesions that you will find are fissuring and lichenification. Okay, so all of these stages, pruritus is a prominent feature. Okay, so eczema or dermatitis affects 10% of the population, no? As mentioned in the previous slide, the presentation may differ depending on the stage of the lesions. Okay, so you should be able to know that when it's vesicular, they are in the acute stage, when there's scaling already and the subacute, and when there's lichenification already, it's in the chronic stage. As it becomes more chronic, there can have secondary infection as a complication. So when they have secondary infection, aside from being pruritic, it becomes painful already. Now, because of the secondary infection. Okay, so the first endogenous eczema, meaning endogenous meaning it's not a reaction to something outside, no? It's really inherent to the patient to have that eczema. So the first is the atopic dermatitis or atopic eczema, which is seen in infants, though majority may also resolve by 12 years old. And then there's another peak. There's also patients, I mean, that we see also until adulthood. It may be prevented by breastfeeding, but usually it presents as pruritus and inflammation. So as mentioned earlier, the dermatological term for each is pruritus, no? So you should be familiar with that. Okay, we can do pre-test to test for common allergens and serum IgE, especially for infants. And we treat them with emollients, topical steroids, and antihistamines. Okay, to control them and relieve them of the itch. So this is very important for you to know that the distribution differs depending on the age of the patient. Okay, like for infancy, so the typical morphology and distribution is age specific. Okay, like for infancy, the lesions are generally acute and the involvement usually is the face, the scalp, and the extensor surfaces. And the diaper area is usually spared. So this differentiates it from other eczematous conditions. For children, like this age na, no longer an infant, the lesions show already signs of chronicity, and they are localized to the flexural folds of the extremities, the antecubital, the popliteal, dorsal ankle, the neck, the nape area. Okay, for adults, the distribution is almost similar with that of the children, the flexural surfaces as well. Okay, you should be familiar with the distribution as the distribution is part of the diagnostic criteria for atopic dermatitis. Okay, so what's the pathogenesis of atopic dermatitis? First, these patients have skin barrier dysfunction or defects because of impaired filaggrin production and reduced ceramide levels. So basically, this skin barrier or defect is quite genetic, no? May genetic predisposition yan. Okay, with having a skin barrier or defect, you have increased transepidermal water loss. Hence, patients have dehydration of the skin and they have cirrhosis. Adding to that, they also have immunoglobulin E reactivity. Okay, so as I mentioned, this has a genetic component. Hence, these patients have usually they have a personal or family history of atopy. So what comprises atopy? These are your asthma, your bronchial asthma, allergic rhinitis, or even allergic conjunctivitis. Okay, so these patients, usually, they are the ones that also have atopic dermatitis. Okay, and inherent or baseline nila is they have cirrhosis of the skin or their skin is very dry. Okay, so the diagnostic criteria for atopic dermatitis, because atopic dermatitis we diagnose clinically, no? We can diagnose clinically without the use of laboratory testing, but we follow this diagnostic criteria by Hanifin and Rajka. So here you have major criteria and you must have 3 of these 4. So ano yung apat? First is pruritus. Second is the typical morphology and distribution, which, as I mentioned, differs with the age of the patient. So you should be familiar with that. Third is it is chronic or chronically relapsing, meaning on and off, pabalik-balik. It's not just a one-time condition. And fourth, you have a personal or family history of the atopic disease as mentioned earlier. And we have several minor criteria. So these are actually 22 minor criteria and you just need to have at least 3. So, pwedeng cirrhosis of the skin, that's common. Ichthyosis vulgaris, ito yung parang may fish scale sa legs. You might have seen that already. Keratosis pilaris, yung what they call chicken skin sa arms usually. Hyperlinear palms, these are those with palms and soles na sobrang madaming lines. Rough and with lots of lines. Okay. And the others are IgE activity, elevated serum IgE, and yeah, all of those. Cheilitis is dryness around the lips. Here, recurrent conjunctivitis is part of the minor criteria as well. Okay, Denny Morgan fold, it's this one. No? Infraorbital fold. Parang makapal yung infraorbital, maraming lines din. Okay, orbital darkening, it's another. Facial pallor or facial erythema. Itch when sweating, intolerance to wool and lipid solvents, peripheric follicular accentuation, they may have food hypersensitivity. White dermatographism or delayed blanch to cholinergic agents. White dermatographism is when you scratch the skin using your nails, for example. There will be a white line, diba? Because it shows dryness of the skin. So we call that white dermatographism. Okay, so those are the minor criteria by Hanifin and Rajka. So that's the diagnostic criteria for atopic dermatitis. By the way, if you just listen to my lecture, you'll be able to answer all of the questions that I gave for the exam. Okay, so prognosis of atopic dermatitis, it is a chronic and chronically relapsing condition. Okay, 40% would remit during childhood, with occasional recurrences during adolescence, but disease may persist for 15 to 20 years, but is less severe. Okay, so complications, they can have exfoliative dermatitis meaning almost whole body or 90% of the body is affected. As I mentioned earlier, secondary bacterial infection is a very common complication of your eczemas. Eczema herpeticum is when your eczema is complicated by herpes virus. Okay. Okay. The second endogenous eczema is your seborrheic dermatitis, also very common. It presents as red, scaly, crusty, pruritic eruption on the oily areas of the skin. So ano yun? The face and the scalp. So it can present on the face and the scalp. So this is a picture from the book, our Fitz book. Okay, so when does it occur? It can occur during infancy, puberty, and then young adults, no? Yung very common ages na we see seborrheic dermatitis. So this is common in people with oily skin or hair and may occur during times of physical stress and may also become worse depending on the season. Actually, they're worse kapag medyo malamig yung season or the transition from hot to cold. So it presents as yellowish, pwedeng greasy or dry scaling. Those are your secondary lesions. And then, ang primary lesions nyo for seborrheic dermatitis are the macules and papules. So these are usually seen on the hairy areas of the head, the nasolabial folds, can be seen on the axilla groins, especially for infants, and genitalia as well. It's a common area for your center. It can be hereditary. It can be due to an abnormal immune mechanism, as I'll show later, its relationship with HIV. Okay. It can also be due to an increased overgrowth, increased epidermal turnover, hence the overgrowth of your Malassezia species. Because the Malassezia species is parang ano natin eh, it's part of our skin or it resides in our skin. So sometimes there's overgrowth. Okay, and sebaceous glands also may play a role. Okay, so it can be triggered by certain underlying medical conditions like Parkinson's and, as I mentioned earlier, HIV or immunosuppressed patients. Exogenous factors would be low humidity and cold temperature. So those who are always in air-conditioned, cold air-conditioned rooms with low humidity are prone to have seborrheic dermatitis. It can be also triggered by deficiency, vitamin deficiency, like with zinc and biotin deficiency. Prognosis, it's chronic and relapsing. Okay, so this is an important slide, no? The association of seborrheic dermatitis and HIV, because in patients with HIV, we see very extensive seborrheic dermatitis and they are refractory, meaning mahirap gamutin. Okay, this is noted in up to 83% of HIV seropositive and AIDS patients. And the clinical symptom may appear as parang SLE. I believe you've had lecture already on SLE. Kasi it can appear as a butterfly rash. So sometimes it's mistaken for SLE. Okay, so it is associated with the reduction of their T cell function. So their sebderm gets worse as the CD4 lymphocyte count decreases. Okay, hence we make the seborrheic dermatosis as one of the indicator for evaluating the progression of AIDS among patients that are HIV positive. Okay, so again, it's very common. I'm sure some of you already had sebderm. There are recurrences and remission, especially on the scalp. Management is a challenge because nga it's on and off. So we give topical steroid, topical glucocorticoids, no, topical antifungal like your ketoconazole, yung mga Nizoral, yan, narinig nyo na yan, and UV therapy. Okay. If you have any questions, you can type them in the chat box and then I'll try to read them later, no? Okay. So next would be your dyshydrotic eczema. There. So this presents as vesicular type of hand and foot dermatitis. So the primary lesion here are vesicles. These are actually deep-seated, tapioca-like. It's characterized in the book as tapioca-like vesicles. Okay, so it can be acute, but they are also chronic and recurrent, and usually located at the sides of the fingers, their palms, and soles. It's very itchy. Okay, and so these are deep-seated, pruritic, clear, tapioca-like vesicles. Those are your primary lesions. But when they are already infected, or when they are in the subacute or chronic stage, you'll find scaling, fissures, and lichenification. For this hydrotic eczema, eruption is usually symmetric. Okay, so kung meron sa left hand, meron din usually sa right hand. Pag wala, we think of something else. Okay, because for this high, it's usually symmetric. And if you have coalescence of vesicles, like nagtabi-tabi yung small vesicles to become a large bullae, we call that pompholyx. When this occurs, especially sa feet, sometimes it's too painful already that patients already have difficulty ambulation. Okay, so in this hydrotic eczema, your pruritus usually precedes the eruption, no? So patients kating-kati siya, they scratch, and then eventually they'll notice there's appearance of these deep-seated vesicles because of the intense pruritus. And then if you erode the vesicles, sa kakakamot na din, then you'll have pain after that. And the very common complication is your secondary bacterial infection. So, you'll know that you have secondary bacterial infection when you already see pustules, so may nana na, no? Meron ka ng yellowish exudates na lumalabas. Or cellulitis, there's already swelling, so you already have the signs of inflammation here. And then you can already also have lymphangitis or lymphadenitis also. Okay, so our management, hydration, basically for all the eczemas, our management is to hydrate the skin with moisturizers. And we give corticosteroids. The potency of the corticosteroids would depend on the location of the skin and the type of the lesion, whether it's acute, whether it's wet or dry. For your dyshydrotic eczema, because it's located on the palms and soles with medyo thick, mas thick yung skin natin on the palms and soles, we give topical high-potency corticosteroids. Sometimes you also inject the steroids so that it will be absorbed well, no, in the epidermis. Okay, we can give oral prednisone, antibiotics when there's already secondary bacterial infection. Okay, so prognosis, this is the very common prognosis for your eczemas. It is recurrent on and off. No? Recurrent attacks are the rule for most, especially for your endogenous eczemas. Okay, next would be your nomular eczema. Nomular meaning parang coin. Okay, because they are round. There. Yeah, those are your nomular eczemas. So again, they are chronic, pruritic, inflammatory dermatitis and presents as discrete, coin-shaped erythematous, edematous plaques. So these are plaques and they are round, erythematous, and coin-shaped. Okay, so actually, these plaques are composed of grouped small papules and vesicles. So initially, they would present as papules, but eventually, when they come to us, usually they already coalesce na into plaques. And then you'll have, this is the one that usually presents with oozing, crust, and scale. Okay, it's very common on the extremities, lower legs, the dorsa of the hands, the extensor surfaces of the hands, and it's also very pruritic. So this differentiates the pleuritis is one aspect that differentiates it from your bony or your tinea corporis, because your tinea corporis would also present as round plaques, pero not very pruritic. Maybe pruritic, but not so much compared with your nomular eczema. Okay, so triggering factors, cold weather, cirrhosis again if you are dry skin, and also seen in atopic individuals. So some atopic individuals would present as atopic dermatitis with nomular eczema. Okay, and again, a complication is your secondary bacterial infection, usually with staph aureus. Prognosis for all endogenous eczemas is a chronic course that can be chronic and relapsing. Okay, again, management, we hydrate with moisturizer, we give potent topical corticosteroids. We also have steroid-sparing agents like your topical calcineurin inhibitors. We can give phototherapy, antibiotic if it's secondary bacterial infection, sedating antihistamine to relieve them of, to be more comfortable, to relieve them of the itch, especially at nighttime, and intralesional or systemic corticosteroids. Okay. Next would be your lichen simplex chronicus. So based from the name, medyo madali siyang diagnose. It's lichen, if you remember your secondary lesion like lichenification, and then chronic. It's a chronic condition, then it's called lichen simplex chronicus. So it's a chronic, severely pruritic disorder. It is severely pruritic such that your patient would rub and scratch it all the time. So because of the repetitive rubbing and scratching, the lesion will become lichenified. Okay? So this is also associated among patients with atopic dermatitis since they have dry skin and they would have the pruritus. Okay? Okay, so this is characterized by one or more but not so much. Medyo few lang yung lesions nila. Circumscribed, sharply defined lichenified plaques, arising from the confluence also of small papules. So what do you mean by lichenification? If you remember your secondary lesion. So this is a thickened skin with accentuated skin markings. Okay, alternatively, they may also exhibit a follicular pattern of accentuation. Parang ito. Follicles siya. Yung follicles yung nag-accentuate. So these are multiple small, closely set papules. And because of scratching, on top of the accentuation, you also have your excoriations. Okay? So common site of involvement here are the scalp, nape of the neck, extensor aspects of extremities, ankles, and anogenital area. Okay, prognosis, like especially this one, it's chronic. Prognosis, it can last for decades. Okay, unless the patient would stop rubbing and scratching. That's the ultimate reason for having LSCs when you rub and scratch all the time. Okay, differentials mo, it may look like psoriasis, it may look like Yersinia corporis, but mas prominent here is the lichenification. Okay, management, first and foremost, stop rubbing and scratching. Okay, so sometimes we need to teach behavior modification for these patients. At the same time, to hydrate with moisturizers. And same management as the other forms of dermatitis. Steroids, antihistamines. Okay. Okay, for your endogenous eczemas is your prurigo nodularis. Okay, what's the difference? It's also a pruritic disorder, it's also chronic, so it's also almost similar to your LSC or lichen simplex chronicus. But this time, based from the name also, you can infer that it presents as nodules rather than plaques. Okay, so there it results naman from repetitive picking then and scratching. So aside from scratching yung pinipik, talagang kinukot-kot repetitively. That's why it's also called picker's nodules. Okay, so again, it's associated with your atopic dermatitis. That's why your patients have pruritus because they have psoriatic skin and also some systemic causes of pruritus. So this one is common among patients with chronic kidney condition. Okay, because the CKD causes the pruritus and hence they have like picker nodules or prurigo nodularis. Prominent symptom is of course your pruritus. Okay, so it presents as hyperkeratotic, meaning rough, no? Hindi siya smooth, yung nodules niya rough. It's firm, dome-shaped nodules. And often it's eroded or kinutkot, no? Excoriated and sometimes ulcerated like this one. Kasi kutkot ng kutkot. Okay, so patient dig into them with their nails. Okay, and these develop on sites in which there's persistent itching and scratching. And usually there are multiple on extremities. Unlike with your LSC, we only see solitary or few lesions. Here, usually we see multiple lesions. Okay, management, like in LSC, you also stop the picking and scratching and you hydrate. And same management as the other steroids. Yeah. And the prognosis is it may persist for months after the trauma has been discontinued. Okay, do you have questions before we end the endogenous eczemas and start with your viral skin infections? Ayan. No questions yet? Okay, you can just type in your question if you have one. Ayaw mag-reach. Okay, so let's go to your viral skin infection. So varicella, what's chickenpox? Varicella is chickenpox, sa Tagalog, bulutong. Okay, so it's a highly contagious exanthem that occurs most often in childhood. Actually, karamihan, most of the viral infections I'll be discussing are more common among childhood, except for your herpes zoster. Okay, so this occurs most often in childhood. The mode of transmission, the major route is respiratory tract by airborne droplets or aerosols, but it can also be spread by direct contact. So the etiology of your varicella is varicella zoster virus. So VZV, varicella zoster virus. Remember that. It is the result of primary VZV infection in a susceptible individual. It results to a lifelong latent VZV infection. So you have a lifelong but latent infection of the sensory and autonomic neurons, and you also have host na, I mean, you're already immune. The host becomes already immune to your varicella zoster virus. That's why you only get this one time in your lifetime. But once you get this, you already have the virus in your sensory and autonomic neurons, though it's latent. Thus, this is important when I discuss the herpes zoster infection. Okay. So it has a prodrome of 2 to 3 days of mild fever, chills. Oh, yan. So you have flu-like symptoms, no? Sore throat and dry cough. And then you'll have the rash. Usually begins on the face and scalp and spreads rapidly to the trunk with relative sparing of the extremities. The lesions are scattered, so they are generalized. They are not clustered, they are generalized, reflecting viremic spread to the skin. So there, these are your clinical presentations. They progress sequentially from rose-colored macules, magsimula lang siya na macule, to papules, and then there will be vesicles. Eventually, there will be pustules and crusts. So the vesicles, yan yung pinaka-characteristic niya. We call that dewdrops on rose petals. So you have vesicles, or those are clear vesicles on top of an erythematous base. So remember, dewdrops on the rose petals. Lesions on all stages are usually present at the same time. So at one time, you can have macules, you can have papules, patient may have vesicles, pustules, and crusts. And the lesions are very periodic. Okay, so in immunocompetent children, the systemic symptoms are usually mild, serious complications are rare. In adults and immunocompromised persons, it can be severe and may also be associated with life-threatening complications like pneumonitis and encephalitis. So laboratory exam that we do in dermatology is we can do Zank smear. So we scrape from the base of the vesicle and it will show multinucleated giant epidermal cells. Okay, so those are your multinucleated giant cells. That's called Zank smear. Okay. We have vaccination for varicella. It can be given at the age of as early as 1 year old. No, so this is live attenuated varicella vaccine. Okay, that's why medyo nabawasan na rin yung incidence of varicella. Management, it's supportive as all viral infection, it's self-limiting. So you can just have supportive management. We can manage the skin lesions, especially if they become secondarily infected with bacteria. We can give antiviral agents. It decreases the disease severity, but it will only be effective if given within 24 hours of onset. Okay? Past 24 hours, it decreases its effectivity, the antiviral. Okay, so the antiviral available here in the Philippines that we give, valacyclovir and acyclovir. Okay, famciclovir is not available. Okay, next is your herpes zoster. Okay, herpes zoster in layman's terms is called shingles. Okay, so it is characterized by unilateral dermatomal pain and rash. So it's more common on older adults and immunocompromised individuals. And this is less contagious na than your varicella. Varicella is very contagious. This one is less contagious. The major route of transmission is your direct contact with the lesions, or it can also be airborne via aerosols, but it's less contagious. Okay, remember that I told you that your varicella, your VZV becomes latent in your axons, no? This one, it's still the same virus, but it reactivated. during adulthood. No? So it results from reactivation and multiplication of a latent VCV that persisted within the neurons following varicella. So patients who have herpes zoster are those that had varicella like years prior. Okay, so your VCV travels down the sensory nerve to the skin where it erupts with vesicles. This time, it's no longer generalized. It erupts in a dermatomal pattern. So what is I'm sure you know your dermatomes, diba? In neuro. So, in your anatomy, no? So, it will erupt in a domothermal pattern and unilateral lang. Usually, it erupts in 2 to 3 dermatomes. Okay? So, like here, it can present just, okay. This is a picture of your chicken pox, 'di ba? After chicken pox, it will resolve, but your virus lives in your axons. And then it will reactivate. Like here, it's just the dermatome, 2 to 3 dermatomes, and then on unilateral. I think I have pictures there. I have pictures later. So prodrome, in difference in prodrome is there will be pain, 1 to 3 days of pain. Before there are lesions, patients would feel pain on that area, tenderness, paresthesia, and allodynia in the involved dermatome. Okay, and then after that, patients would also have mild flu-like symptoms, and then they will have the lesion similar to your varicella, except that this time they are already grouped vesicles, and we do Zank smear as well and see multinucleated giant cells. Okay, there. So these are now grouped vesicles. They may start as macules and papules, then become vesicles. And in a dermatomal level, we follow like 2 to 3 dermatomes on unilateral. Hindi na siya generalized. Okay? So it presents as closely grouped vesicles on an erythematous base with a unilateral distribution, localized with the area of the skin, innervated by a single sensory ganglion. Okay. So complications, 10 to 15% of cases would involve the ophthalmic division of the trigeminal nerve. Okay, and very particular involvement of the nasociliary branch of the ophthalmic division of the trigeminal nerve. So this is the branch that innervates the eye, as well as the tip and side of the nose. So this one, it provides your varicella direct access to intraocular structure. So this is the one that we check, no, the tip of the nose. Thus, when your zoster involves the tip and the side of the nose, we call that the Hutchinson sign. And it's important to refer the patient to ophthalmology for co-management to prevent ophthalmic complications and possible blindness. Okay, because of the affectation of the nasociliary branch of the ophthalmic division of the trigeminal nerve. Okay, and it is also the one that innervates your eye. Okay. Patients also would have post-herpetic neuralgia. What's that? So it's chronic neuropathic pain that persists long after the rash resolves. It may be very debilitating, such that some elderly patients, even a year after the rash resolves, they still feel the pain. Okay, it's one of the most common debilitating complication of herpes zoster. Vaccination, we already have shingles vaccination. It's quite recent, no, the launching, probably mga 2 to 3 years ago pa lang. And it's quite expensive, but it's recommended for people 50 years old and above. Okay. We also give pain management, antiviral therapy, and analgesics like gabapentin and pregabalin. Okay. So like any viral infection, it's self-limiting. So the primary management is supportive, bed rest, increased fluid intake. Skin lesions we manage if you see secondary bacterial infections. The antiviral agents may also help, of course, to reduce the time to healing and the duration and severity of acute pain, especially in older and immunocompromised adults. But this should be given within 72 hours of rash onset. So for varicella, it should be given within 24 hours. For your herpes zoster, it should be given within 72 hours. Okay, so this is the protocol for antiviral treatment for zoster in normal and immunocompromised host. Okay. Okay, so we're done with the varicella zoster virus infection. We now go to the other viral exanthems. Yung varicella kasi is presents with vesicles, right? Next, this naman, the exanthems would present with your maculopapular rash. Except for the hand, foot, and mouth pala later, may also present with vesicles. Okay? Say rubiola or measles. So remember, measles is rubiola. German measles is rubella. Okay? Measles or rubiola. The etiologic agent is Paramyxoviridae. And you have fever, malaise, cough, coryza, and conjunctivitis. Okay, and the lesions present as with craniocaudal spread, initially on the face and neck, and then in 2 to 3 days, it will spread to trunk and arms. Rubiola or measles, it will be eventually would coalesce, no? So the multiple erythematous macules and papules would coalesce in a generalized distribution. Important to look at the Koplik spots on the buccal mucosa as these are pathognomonic. Here, there. No, in your buccal mucosa, you will see Koplik spots. So these are tiny white lesions or grains of sand surrounded by an erythematous halo or red papules on the buccal mucosa opposite the premolars. And it may precede the rash by 1 to 2 days. This one. Okay? Symptoms, it's usually non-pruritic. Complications of measles would be pneumonia and post-measles encephalomyelitis. Okay? And then prevention would be your vaccine management is supportive. We don't have antiviral, don't give antiviral meds for your measles. Okay, rubella or German measles. It's also called the 3-day measles. The etiologic agent is togaviridae. It has a short prodrome, low-grade fever lang, yan, conjunctivitis, rhinitis. And here you look for the Forsheimer spots. So these are the enanthems of your viral infections. Forsheimer spots is the petechiae and the soft palate. And evolution of lesions of your rubella or German measles is craniocaudal spread, face progressing to the neck, and in 1 day, you spread to trunk and extremities versus 2 to 3 days in your measles. Kaya in 3 days, magaling na sila. That's why it's usually called the 3-day measles. Okay? Here, it's very mas prominent yung enlargement of the cervical, suboccipital, and post-auricular glands. Your lymphadenitis, more prominent with your German measles. It may be pruritic, and with your German measles, there's a higher risk of fetal malformation with congenital infection. If your pregnant patient gets German measles, no, it's high risk for fetal malformation like microcephaly, congenital heart disease, and deafness, particularly if they get the infection in the first trimester. Okay. There's also rubella vaccine, no, German measles vaccine, and management is supportive. Next is erythema infectiosum, or the fifth disease caused by parvovirus B19. So it's also called a slack cheeks appearance kasi it's a childhood illness followed by their mukha siyang sinampal, no? Slack cheeks. So this is an erythematous lacy eruption on the trunk and extremities and the face. Okay, so there is confluent erythematous edematous plaques on the malar eminence, hence the term slap cheek, and they may recur for weeks or months. Okay, in your extremities, you have papular purpuric gloves and socks syndrome. So, kanina ko cover usually ng gloves and socks, yun yung mapula. That's the pruritic erythema, edema, and petechiae of the hands and feet. Okay. Accompanying symptoms of your erythema infectiosum is symmetric polyarthritis, particularly of the small joints in adults. And it can be complicated by your aplastic crisis in patients with increased red blood cell turnover, chronic anemia in immunocompromised persons, and fetal hydrops in pregnancy. Management, again, is supportive as it can be self-limiting. Okay. Pause. Let me just charge my laptop. You can type in your questions. Alam ko meron nag-type in their question. I'll read them after this. Um, viral section. Okay, exanthem subitum is Rosola infantum or 6 disease. Okay, it has higher prevalence in general population by the first year of age. So, pambata din siya. It's caused by human herpes virus 6 and 7. So, it presents as rose-colored macules and papules surrounded by a white halo over the neck and trunk. And patients may also have palpebral edema, Nagayama spots. These are erythematous papules involving the mucosa of the soft palate and uvula. Symptoms of this, patients have high fever. Okay, they're very irritable, high fever, and then runny nose, no, rhinorrhea, and diarrhea. A complication is reactivation in immunocompromised individuals is a cause of morbidity. Okay, so your HHV6 infection can occur when the virus reactivates in the setting of immunosuppression. That's why it might happen as well in adults, but that's already because of immunosuppression, particularly in patients that are undergoing or had stem cell transplantation and solid organ transplantation. Okay, last is your hand, foot, and mouth disease, very common lately, no? Etiologic agent usually is Coxsackie virus A16 and enterovirus 71. So it's a viral exanthem seen most commonly in children, but rarely in puberty and young adults. We've seen this also, but it's quite rare. Okay, we see erosions in the mouth, oral erosions of the tongue, buccal mucosa, hard palate, and oropharynx. And then there's eruption of papules and vesicles on the palms and soles. So characteristic ng papules, no vesicles rather, is the football-shaped erosions, no, surrounded by an erythematous halo. So hindi siya dewdrop on a rose petal. It's football-shaped vesicles and with erosions. Okay, patients may have mild constitutional symptoms like low-grade fever, malaise, ayan, abdominal pain, or upper respiratory tract infections. It's highly contagious. That's why kids nga sa classroom, pag mayroon nagkaroon ng isa, madami agad, no? It's spread from person to person via oral to oral and fecal to oral routes. Management, symptomatic, and supportive care. So ito, here you see, yan siya, football-shaped. Mas common. Ito, yung mga ganyan. That one. Medyo elongated ng konti. So, symptomatic and supportive care is the management for all naman your viral infections, di ba? It can resolve spontaneously without serious sequelae in majority of cases. It may have serious complication when caused by your enterovirus 71, like CNS involvement and pulmonary edema. Okay, so again, supportive management, there's no specific antiviral therapy for your hand, foot, and mouth disease. Supportive meaning we treat the fever, fluid and hydration, we give that, and we manage complications like if there's bacterial superinfection. Okay, so just remember the routes, no? The routes of transmission for rubella, erythema infectiosum, exanthem subitum, and your hand, foot, and mouth disease. Among all of these, your hand, foot, and mouth, siya lang yung merong fecal-oral route. Okay, most of this is airborne or direct person-to-person contact. Okay, I think there's a question before I go to our skin infestations. Good day po. Sa atopic, okay. Sa atopic dermatitis po, wala po specific management. Like moisturize lang din po. We give, moisturize of course, that's number one. That's the mainstay of management. But we give topical corticosteroids. Like I mentioned for all the other eczemas, no? We give topical corticosteroids. If that doesn't work topical, we can also give systemic, but rarely do we give the oral corticosteroid because of possibility of rebound phenomenon. We can give your topical calcineurin, which are your non-steroidal or steroid-sparing agents. We can also do phototherapy. But very important kasi as management for these cases are your moisturize, no? Mild emollient, frequent moisturization. Okay. Are there any other questions? Okay. Okay, let me go to your skin infestations. I believe this was already discussed by Dr. Yang, no? So I'll just run through them. So you can have arthropod bite, hypersensitivity reaction. So these are the people na yung kagat sa kanila is hypersensitive or hyper-exaggerated. Arthropod bite, meaning we cannot be very specific, no? There's no way for us actually to be sure which arthropod has bitten you, no? There may be some difference in characteristics, pero still we cannot be 100% sure. Okay, so arthropods are defined by an exoskeleton, segmented body, and jointed appendages. And many species are capable of inflicting bites and stings on humans. And we people are usually unaware of having been bitten. Okay, so the cutaneous reactions to bites are inflammatory or allergic reaction. So, common characterization is intensely pruritic. Makati talaga yung site of the bite. Whether immediately or minutes to hours or even days after the bite. And yun nga, it may persist for days to weeks. Okay, yung systemic symptoms naman may occur in association with toxin or allergic reaction to the substance injected during the bite. Pwedeng mild lang, it can be severe, life-threatening, like when you get anaphylactic shock from a toxin or an allergy. Okay. Manifestation can be solitary or group, depende, no? Kung gaano karaming bite yung nagawa sa inyo. So it can present as urticarial papules, eventually can be vesicles, and in some cases can present as bullae. Okay, like for example, here, papular urticaria, yan, these are vesicles and can be large to become bullae. Secondary lesions, very important. Actually, the bite, it can be persistent and then it can resolve din naman after days when the hypersensitivity is gone. But we can get secondary lesions from scratching, no? So patients can have secondary infection with their Staphylococcus aureus. So how do we know that it's a bite? Usually it's a vesicle or papule with a central punctum on top of the papule. So sa gitna, nakikita natin yung kung saan nag-bite yung arthropod. Okay, so we call that the central punctum. Okay, it may heal with hypopigmentation, which is temporary naman. Okay, or raised or depressed scars, but that's quite rare. Okay, sige. We can skip this. Okay. So we can give steroids for pruritus pag persistent. We give topical corticosteroids. And rarely do we give oral corticosteroids as well. For secondary infection, we treat with antibiotics, topical or systemic, depending on how severe the infection is. And we can also give antihistamines for the itch. Tetanus prophylaxis may be required for bites of several terrestrial arthropod species. Antivenom, rarely naman yung mga yan. Okay, so mosquitoes, very common, that usually causes the bites, no? And presents usually with urticarial or eczematous presentation. And usually, it's on the exposed sites. That's one clue for mosquito bites. On exposed site, arms and legs. Your bed bugs, on the other hand, can present even in unexposed areas kasi natutulog ka eh. Pwede na siyang gumapang sa'yo, no? So, exposed skin but also on the unexposed areas of sleeping humans. Okay, so pwedeng sa face, sa neck, sa arms, and then they are grouped usually. We call usually group of three. Tawag namin doon breakfast, lunch, and dinner sign. So, nag-breakfast na siya dyan while you're sleeping, nag-lunch na siya dyan, and then nag-dinner na rin siya dyan. Okay, so those are group papular urticaria occurring at the bite sites. And a clue also, we ask the patient if there's reddish brown streaks on the mattress of their bed. So because your bed bugs, they defecate the old blood meal while ingesting a new meal. Okay. Next skin infestation would be your pediculosis capitis. Ano yun? Yung kuto. Okay? So these are in infestation of humans by lice. There are three species, the Pediculosis humanus capitis. These are your head louse. Pediculosis humanus humanus, this is the body or clothing louse. And your Thyrus pubis or pubic or crab louse. I'll show you later kung saan yung mga yan. So, patients would present with pruritus. And this is because of the secondary to delayed hypersensitivity reaction to your lice. And that's why after initial exposure pa, magkakaroon ng pruritus. So, madami na yung kuto by then, no? 2 to 6 weeks after initial exposure, dun palang mangangati si patient, dun niya palang mapapansin na may kuto siya. Okay, so your pediculosis capitis, so this is the itsura ng iyong head lice. That's the infestation of the scalp by the head louse. The etiologic agent is your pediculosis humanus capitis. Okay, so it lays its eggs or lisa. No, we call in Tagalog. It lays its eggs or nits on the hair within 1 to 2 millimeters of the scalp, and it will hatch within 1 week, passing through nymphal stages and maturing to adults over a period of 1 week. So transmission is spread by close physical contact, especially head-to-head, sharing of headgear, combs, brushes, pillows, theater seats. Ayan. O, sa mga theater. Sa sinehan. Okay. It occurs worldwide, affecting hairs of the scalp, and most commonly in children between 3 to 12 years of age. So symptoms is pruritus of the back and sides of the scalp and nape. Yan, usually ang una namin titingnan yung batok kasi yun yung unang-unang mangangati yung patients. And sometimes, the nape area would have papular urticaria as well. Minsan yun yung kino-complain. May mga pantal, may makati sa batok. Hindi nila alam. They have pediculosis capitis. It can be secondarily infected due to chronic scratching and rubbing, no? With your Staphylococcus aureus. So, when there's secondary infection, we see already lymphadenopathy, occipital and cervical lymphadenopathy. Okay, so this is your NITS or your LISA. Okay, we can identify the pediculosis capitis by the eye, or we can do our microscopy and dermoscopy as well. Okay, when you see the pediculosis capitis, confirmatory na yun. I mean, the head lice rather. Confirmatory na yun to have pediculosis capitis. Management. Yan. If you're curious about the management, it's easy naman. We give permethrin shampoo. That's our first choice. Especially sa Philippines, mukha namang wala pang resistant to permethrin. It can be given for patients as greater than 2 months old. So we apply sa damp hair, leave it on for 10 minutes, then rinse off. Then repeat after 7 days. It's not done daily. It's just usually 2 course, 1 week apart. But important in the management, kahit gawin natin to without this, it will recur, no? So important to treat all household members. To wash combs, and then iron fabrics, seal in plastic bag for 2 weeks. To do general cleaning at home, as the lice can survive away from the scalp for the next 4 days. Okay, we can also give pyrethrin shampoo, your lice Alice. Same instruction as your permethrin. Okay, some would do the physical method, shaving one's head. Okay, ubusin lahat ng hair. Though we do not recommend naman. Kawawa naman yung kids. Okay, aside from that, no, we also request our parents to do manual removal of the nits and lice. You can apply Cetaphil also or plain petroleum jelly to suffocate the nits and leave on until for 2 minutes until the lice are expected to slow down on their movements, and then to remove the nits and the lice using fine tooth comb. Okay. So this regimen, no, your fine tooth comb together with the Cetaphil lotion or plain petroleum jelly, you can do this daily for the next 24 days to remove all the nits and lice as your adjuvant to your Quell lotion or Quell shampoo rather. Okay, next is your pediculosis pubis. So this is caused by Thyrus pubis, your crab or pubic louse. So in its name, saan siya nakatira, not in your head, but in the genital area, no? Your pubic hair. Okay, so it prefers a humid environment. So other hair-bearing areas aside from the pubic are your axillary area, mustache, beard, eyelash, eyebrows. It can also inhabit your scalp, pero rare, mas common yung isa, yung pediculosis capitis. Okay. So transmission of this can be during physical contact, sharing of bed, and sexual contact. So if you see this in one of your patients, it can may coexist with other sexually transmitted infections. Not so kita here, no? Medyo mas mataba siya. Mas elongated yung the one that causes pediculosis capitis. Your crab lice, mas mataba. Here. So rather than your nape, you will have the papules or the parietus here in this area. And secondary lesions again would be excoriation and lichenification and possible infection due to your rubbing. Okay? Okay. Yan, di ba? Yan, these are nits on your eyelash. Okay, so these can also be diagnosed by eye, hand lens microscopy, or your dermoscopy. Okay, management, topical treatment options similar to your pediculosis capitis, using permethrin and pyrethrin, repeat after 7 days. Hygiene, decontamination of clothes and beddings. Important here is to treat also the sex partner. So we do contact tracing and we screen also for other sexually transmitted infections. Okay. Before I proceed with acne, any questions? I'm sure everyone's interested with acne. None so far? Okay. So let's proceed. We're halfway through the lecture. Sakto, 1 hour. Okay, let's proceed with your acne and rosacea. As it's one of the most common reasons patients go to our clinic, no? Acne. Okay, what's acne or acne vulgaris? So basically, it's pimples. Okay? It is a papulopustular inflammatory condition affecting the face and trunk, affecting 90% of adolescents. So it is due to the overproduction of sebum, which blocks the sebaceous duct and leads to the formation of comedones. So comedones, yun yung blackheads and whiteheads. Okay, then after that, there will be colonization of Cutibacterium acnes. Excuse me. And complication of this, it causes residual scarring if the patient keeps on picking on the lesion or the lesions are neglected or not treated for a very long time, no? Nagkakaroon tayo ng scarring. So it's a multifactorial disorder of the pilosebaceous unit, and it's more severe among males than females. The severity is quite hereditary. Okay? So there are 4 key elements of the pathogenesis of your acne. First is your follicular epidermal hyperproliferation. Okay. Second is your sebum production. Third is the presence and activity of your Cutibacterius acnes. This is previously known as your Propionibacterium acnes. And last, it's inflammation and immune response. So basically, it will start as a microcomedone and then it will turn into a comedone when you already have accumulation of shed corneocytes and sebum. And then once it's inflamed, further expansion of the follicular unit, there's already proliferation of your Cutibacterium acnes, it becomes an inflammatory papule or even a pustule. Okay. Once there's rupture of the follicular wall, there's marked inflammation. Yan, nagiging nodule na yung presentation nun. Because there's already mapulang matigas dito na malaki, no? Because of the ruptured follicular wall and the inflammation. And these are the ones that may cause scarring. Okay, so 35% of women and 20% of men have reported having acne in their 30s, while 26% of women and 12% of men were still affected by their 40s. So up to age 40, pwede pa rin magka-acne. And we have 2 types, the non-inflammatory and inflammatory. So non-inflammatory rather, these are your comedones. So you have the blackheads. Alam ko familiar kayo with that. kulay itim siya, and your whiteheads. So blackheads, these are your open comedones. Your whitehead are the closed comedones. Okay. Once the plug inside is oxidized, kasi nag-open na siya, and then it oxidized, it becomes black. That's why once it's open, it's already called blackheads. Okay, now you have the inflammatory type of lesions. These are your papules and pustules. Okay? Yan. Sa face. So it's no longer comedones. These are now your papules and pustules. Okay. Classification, we classify them depending on the number of comedones, number of inflamed lesions, and the number of nodulocystic lesions. So once we already have like more than 10 to 15 inflammatory lesions, that already becomes moderate. And then nodulocystic, yeah, your severe acne. Okay, complications, the erythema or redness, it may take quite some time bago mawala yon. Or the hyperpigmentation, the post-inflammatory hyperpigmentation. And more severe would be your scarring. No? It can also have keloid, especially on the chest and back, and in the jaw area as well. Okay, so how do we treat or manage our acne? First, we have to dispel the myths, no? Yung mga peanuts daw can cause acne, or ano pa ba yung mga myth nila? Like yung medyo may mga kadiring myth yung mga iba. Like kung ano-anong nilalagay nila sa face para hindi sila magkaroon ng acne. Yan. So we also advise on washing face with soap, mild soap and water twice a day. Now we give benzoyl peroxide, that's one of our mainstay. We also give topical erythromycin, clindamycin. We also give tretinoin or our retinoids, and in severe cases, we give isotretinoin. That's your oral retinoids. Okay, this is given or indicated for severe cystic acne. Actually, this is the only medication, your oral isotretinoin, that can manage or that can address the four pathogenic factors in your acne. Remember what I mentioned earlier, no? There are four factors in its pathomechanism. It's the only, okay, sorry. Yeah, it's the only medication that can address all of those. However, we only give this for severe cystic acne because of side effects, no? Medyo madami siyang side effects. Okay. Another condition is rosacea. Why am I discussing? Though it's not as common as acne, it can look like acne. So most patients, they will come, kala nila they have pimples or they're treating themselves for pimples, but actually what they have is rosacea. No? In some books, actually, this is called acne rosacea. But it's different, entirely different with your acne. Okay, it occurs among fair-skinned, middle-aged women usually. So these are already adults. No, they don't come to us as teenagers, but they're usually adults. And they present as chronic inflammatory eruption, the cheeks, nose, and chin, with erythema, papules, pustules, and some dilated vessels, no, called telangiectasia. So our treatment here, they improve with topical metronidazole, and then we tell the patients to avoid the triggers. So they are usually triggered by hot drinks, stress, sunlight, spicy foods, alcohol, and even application of your topical steroids. Okay. So next, we go to your exogenous dermatitis. So exogenous meaning it's caused by something outside of your skin. So here, isa lang naman yung i-discuss ko. It's the contact dermatitis that can have dalawang klaseng contact. No? We have two types, the allergic and the irritant contact dermatitis. Okay. So a clue that your patient has contact dermatitis is the clinical configuration or distribution. This is the most important clue. And here is the ways to differentiate whether it's an irritant or an allergic contact dermatitis. Okay, first, for an irritant contact dermatitis, it may occur in anyone. Okay, it's concentration dependent, meaning mas mai-irritate ka pag na-expose ka sa mas madami. Pag mas konti yung exposure mo, probably you won't get irritated. Okay, there are no papules, but there are fissures. The margin do not spread kung saan lang yung dumapo, yun lang yung may Makate. Or, sorry, not Makate. Yun lang yung may lesion. Okay? For allergic, it happens only among sensitized individuals. Those with delayed type hypersensitivity reaction. This is your type 4 delayed type hypersensitivity reaction. Okay? And it's independent of concentration, meaning kahit isang patak lang, if you're really allergic to that, your reaction can be exaggerated or can be more than that one patak. Okay? So that's why it's already also has the spreading phenomenon. Okay? They present usually with papules with no fissures. Management for both would be identification and avoidance of your causative agent. Whatever is the cause, you should identify, be able to identify sana. Therefore, such that you'll be able to avoid that cause. Okay, let's start with the allergic contact dermatitis. Because it's a hypersensitivity reaction, a delayed type hypersensitivity reaction, it needs previous sensitization, meaning you are already exposed to this before, but you did not react before initially, no? Because it's delayed type. But because of that previous sensitization, the second or the third time that you'll be exposed, you will already have reaction. Okay? So the pattern of eczema will depend on the site of contact. There's a sharp cut off where contact ends. Most of the time, but sometimes they spread na. Autosensitization may occur and it's usually common in the thin, moist skin. So how do we diagnose allergic contact dermatitis? Or rather, di pala diagnose. How do we know where they are allergic to? To what component, what ingredient, what chemical? No, we do the patch testing. Okay? So here we put, later I have a picture, I think, of the allergen. We put small amount of the allergen on the back. And then after 48 hours, our patients would have marked prolonged response to that allergen. Okay, so once we get to find out what allergen a patient is allergic to, we'll be able to avoid it. Or we can tell the patient which food and not food, no, what substance to avoid. Okay, so these are the common allergens. Dinickel chromates. Chromates are seen in cement and leather. Lanolin seen on cosmetics, so you have to check the cosmetic kung may lanolin. Rubber resins, topical antibiotics, and antiseptics. Yeah, no? Some antiseptics can cause allergic contact dermatitis. Okay, example. Here, ACD to lipstick. So whatever ingredient in the lipstick that you're cause allergy to, like lanolin, for example, or even fragrance if your lipstick has a scent, yan, that's ACD to lipstick. Possible ACD to fragrances or flavorings. Here, to dye. For example, patients who dye their hair can have allergy and it will present here on the nape as well and on the scalp and on the forehead. Okay, symptoms, there's itch and swelling, no? So these are the key components of the history and clues to presence of allergy. So patch testing is a diagnostic test we use to identify the causal allergen. And it's indicated for patients with persistent or recurrent dermatitis. So pag paulit-ulit yung dermatitis, so we're thinking already this might be reacting to something. So, and we're thinking already that's allergic contact dermatitis, we do our patch testing. So we can identify the causal allergen. Patch testing, like here, we patch. Each box is one allergen. Ang dami nito, that's 10, 60, that's 100 allergens. Here in UARM, we only have, I think, 30 allergens. So we test them with the top 30 allergens common among Filipinos. That's patched on their back for 48 hours. Do not remove, do not wet. So, hindi mo na sila maliligo for 48 hours. We also ask them to stop intake of steroids and application of steroids. Okay. And then what's a positive? Positive is they will have vesicles and papules on that box like that one. So this is a close-up of that box. Yan, papulovesicular reaction after 48 hours like that. Or even a bit of a swelling. Erythema and swelling. Okay, so kung saang box yon, if that's nickel, if that's dye, yun, dun siya positive. Okay, management of course is allergen avoidance. That's the mainstay. Kahit i-manage natin siya, if it's patient still in contact with that allergen, ulit at ulit yun, di ba? So patient education about avoiding the allergen and related substances. For localized acute flare, we treat with topical corticosteroids as a first-line treatment for 2 to 3 weeks. We can give oral steroid for severe or widespread eruption. So remember, compared with your irritant contact, your allergic contact dermatitis can have a spreading phenomenon. No? Okay, now we go to your irritant contact dermatitis. It usually commonly affects the hands, no? Here, like here in the picture. So you see erythema, but there is already scaling and fissuring. And the common irritants are your detergents for washing clothes, bleaches, and soap. So this is a usual occupational hazard seen among hairdressers, engineers, mga laundry, nag-work sa laundry, okay, tubero, yan, yung mga work na ganyan. Okay. Management, avoiding again of your irritating substances, decreasing the duration and frequency of contact with the irritants. And then emollients to accelerate the recovery. Okay, example, ICD during winter for a healthcare worker na hugas ng kamay or laging alcohol ng alcohol. Yan, there's already drying, fissuring. ICD from topical retinoid. Topical retinoid is ano talaga, usual cause of ICD. If you put it too much or you put in the wrong skin, medyo dry yung skin, then you put topical retinoid, they will have ICD. This is ICD from soap that was left overnight sa area with crease, sa flexural area. ICD from detergent, yan, yung mga hugas ng plates, laundry, okay. ICD from agent used for low back pain. Okay, see, initially, sometimes they can also have vesicles, no? What are the agents used for low back pain? Yung mga, we've seen a lot who use katingko, katialis. Yan, katialis, very common. That causes ICD. Have you heard of katialis? Sa mga lola nyo, naglalagay. Yeah, very common yun. And then industrial solvent, ayan. Pagka napasok kayo with, let's say, Zonrox or muriatic acid, for example, your hand, napaso ng muriatic acid cause that. This is ICD. It's irritant contact dermatitis. As opposed to allergic contact dermatitis, anyone na malagyan sa kamay ng muriatic acid would have this, no? No, sensitization is needed. Okay? It's an irritant. It's an irritation because of the alkali in that. Alkali are the ones that are more usually causes your irritant contact dermatitis. Okay. Before I proceed with psoriasis, kasi it's important for you then to. What is, I read lang question, no, before we proceed to psoriasis. What is treatment po for hypopigmentation due to acne? Okay. First and foremost, if you have acne, kasi very common question yan, dadating yung patient, Doktora, kasi po nangingitim yung scars ko from acne. First and foremost, before we treat the hyperpigmentation, we treat first the acne because it will become a cycle lang, di ba? If you treat the hyperpigmentation, then mag-acne din siya ulit, mag-hyperpigment ulit, di ba? So first treat the primary cause, which is acne. At the same time, we can sabay naman na the hyperpigmentation because your retinoids, in a way, since it decreases your cell turnover, it also, in a way, will lighten your hyperpigmentation. But if, to answer your question, there are a lot naman agents that can help you to, hypopigment ang gusto mo. Okay. I'm talking about hyperpigmentation, no? There are a lot of agents that would lighten, like your niacinamide, arbutin. If you use azelaic acid for acne, it will also help lighten yung mga pigmentation. But for hypopigmentation, it's quite more difficult. Okay, this is less common, yung hypopigmentation due to acne. And it's quite more difficult for it to pigment rather, because you just need to wait for for the integrity of your skin, your epidermis to come back para yung melanocytes mo would produce melanin again. Okay? It's not ano naman, it's not a permanent hypopigmentation eh. It will come back. Okay? If you continue with your anti-acne medicines. The question is, do I need to restart the medication? If you are still having acne, whether, remember, I mentioned the types of acne, non-inflammatory and inflammatory. Your comedones, your blackheads and whiteheads are still acne. Okay? It's your non-inflammatory lesions. So, if you still have that, you still need to apply your um, tretinoin, benzoyl and tretinoin. Okay, usually I tell my patients that's maintenance na until your late 30s. Kasi dun lang sa mga late 30s, dun lang medyo huhupa yung factors that can, you're being oily because of the hormones as well. No, dun lang siya huhupa. So as long as you're on that stage, if you want to maintain having acne-prone skin, you just have to continue your benzoyl and tret. Okay. Scarring, if you're just talking about the hyperpigmentation and hypopigmentation, your benzoyl tret can help you with that. But for depressed scars, it cannot be addressed fully by your topicals. This is the time that you need na your procedures like CO2 laser or even just your microneedling. Yan. Next year, we'll already have laser here in UARM. Tama ba, Lisa? Yes. Yeah. It's already being, inaasikaso na yan, no? So, next year, our section would open laser center. Definitely will have CO2 laser, all of your acne scarring. Ayan. Ipa-laser nyo na dito sa UARM. Okay. Doc, ano po usually gagawin kapag ICD sa retinol na dati hindi naman po nangangati as usual application? Okay. Your retinol products really, ang tawag dito, nakaka-cause talaga siya ICD. Especially if you don't have that oily skin. I'm looking forward na sa laser center. Yes po. Sige. Punta lang po kayo sa lahat ng dermatologists, OPD or mga private derma, then we'll do your laser. Yeah, next year. The target is first quarter of next year. Mm-mm. According to our admin, UARM admin. Okay, where was I? Yan. Retinoids, if you have sensitive skin, if you have dry skin, okay, don't get me wrong, we want retinoids for acne and also anti-aging. If you've heard about retinol for anti-aging, that's true. We want that for anti-aging. It's anti-wrinkle, but it's really has a tendency to cause irritation. So if your skin is quite dry or easily irritated, sensitive, you can start with just every other night application. And the correct amount of application is pea-sized amount for the whole face. So it's very thin. It's a thin application lang. The whole pea-size buong face na yon. Okay, do not apply too much. Yeah, mas magkakos ng ICD. If di kaya ng skin, you start with every other night because your skin eventually would adjust. Like every other night for a week or 2 weeks, and then if hindi na siya nag-sting, di na siya humahapde, you can increase it to every night. And you can start also with a very low dosage like 0.025, though it's hard to look for 0.025. Usually what we have in the drugstores is 0.05. Yan. Retinol burns? First stop muna. That's ICD pa din to your retinol, no? So first stop muna, we treat the retinol first with, the burn first or the ICD with topical corticosteroid. And then once we think the patient's skin has recovered, we can shift to a different, maraming types of retinol, by the way. We have the tretinoin, we have the topical retinoids. We have the tretinoin, we have adapalene, we have the tazarotene. No? What I do pagka gumaling na yung ICD after giving topical corticosteroid, short course lang yon, can be just 5 days to a week. And probably 2 weeks from that, I can start the retinoid. Again, the tretinoin. Kasi kung anti-aging nga ang gusto ni patient or anti-acne. Okay, but yun nga, like I said earlier, very low dose first. I can start with 0.025 every other night or just twice a week, evenly spaced in days. and then see the reaction. So, mabagal lang. But your skin would adjust. You just have to be patient. Yeah. Okay. Akala kasi ng iba magic ano yung retinoid, lagyan nila ng sobrang dami yung face. Ang dami ko nakitang gano'n. So remember the pea-sized amount for the whole face. Yun lang siya. Okay, let's go to psoriasis. What time is it now? Ayan, sakto. 30 minutes for the next. That's more pa. Di lang yan last two topics. Let's go to psoriasis as this is also very important. Okay, this is one of the most common skin disorders that we see. It's a papulosquamous proliferative inflammatory skin disease that affects 2% of the population with a peak incidence in the late 20s. So it's a chronic condition, no? That triggers our stress, trauma, infection, and even certain drugs such as lithium, chloroquine, and beta blockers. Okay. It has equal incidence in males and females. It is hereditary. Can be hereditary with several clinical expressions. Hindi nga lang ganun ka straightforward yung pagiging hereditary niya because its trait can be polygenic, no? But it has been documented that if one parent has psoriasis, there's 8% chance that an offspring will have psoriasis. If both parents, then 41% chance of offspring having psoriasis. There are different types, no, of psoriasis. The most common is your plaque type. It consists of salmon pink plaques topped by a silvery white scale that extensor surfaces of the limbs. Okay, so remember the description. Salmon pink plaque topped with a silvery, usually it's thick then, the white scale, usually on the extensor surfaces of the limbs. You can also have on the scalp. So in the scalp, it presents as thickened hyperkeratotic scales. Okay, and remember this, patients or psoriasis would have positive OSPIT sign. What is OSPIT sign? This is a pinpoint bleeding upon forcible removal of a scale of a psoriatic lesion. Okay. Other types of psoriasis would be your flexural or your inverse type of psoriasis. This time naman, it's non-scaly. Okay? So you have pinkish, glazed, clearly demarcated, non-scaly lesions. So where do we see this? Sa groin, perianal, genital, and inframammary folds. Another type is your pustular type. So it presents with pustules. So you have a well-demarcated scaling and erythematous plaque topped with pustules. The pustules can be white, yellow, green, or sometimes brown, no? But usually naman nakita namin is white, yellow. Okay, it can also be seen on the palms and soles. Okay, extradermal manifestations. I'll show you later a picture of nail pitting. Okay. Remember this as well. Your psoriasis has the Kebner phenomenon, also known as the isomorphic response. This is when traumatic induction of new skin lesions on non-lesional skin. So this means there's appearance of new skin lesions of a pre-existing dermatosis on areas of injury or trauma in otherwise healthy skin. For example, this is a picture of patient with psoriasis na nag-sunburn. Ito ano siya, sports bra. So ito yung na-sunburn. So after the sunburn, patient had psoriatic lesions on the area that had sunburn, but not here. Okay. Why is this important? Because we ask the patients to do not scratch because even if they don't have lesion on that area, if they have scratched it or na trauma, nakaskas na yun, tumama sa something, it can produce new psoriasis lesions. Okay. Aside from the skin, you also have affectation of the nails, no? The fingernails and the toenails can be involved in 25% of patients, especially if your patient have concomitant psoriatic arthritis. So nail involvement actually makes us investigate more if your patient have arthritis as well, since your psoriasis can also affect the joints. Okay, so what can be seen? What are the manifestation of nail psoriasis? They can have nail pitting. So these are small, shallow punctate depressions on the nail surface. It's a frequent sign of nail psoriasis, but the pathognomonic or more specific for psoriasis is your oil spots. Because pitting you can see in other lesions. I mean, in other conditions. But the pathognomonic for psoriasis is your oil spots. So these are the oval, salmon-colored, or yellowish-brown spots on the nail bed under the nail plate. Here, parang this one. Okay. Here, you also have nail spots here. Okay. Onycholysis, so this part naman sa dulo is your detachment of the nail bed from the distal nail bed. And you can also have subungual hyperkeratosis or accumulation of debris between the nail plate and the nail bed due to hyperproliferation of keratinocytes. But this last two is not specific for psoriasis. We also see this in fungal infections of the nail. But remember, the pathognomonic sign, dito mo lang makita sa psoriasis, is your oil spots. Okay. You can also have another form is your guttate psoriasis. This is the eruptive type triggered by acute streptococcal infection. So what happens? Patients would have multiple scattered discrete salmon pink papules and plaques. Smaller siya than the usual plaque-type psoriasis and topped with few scales. This time, it's disseminated and generalized, mainly on the trunk. And it can resolve spontaneously because it's an eruptive type due to your infection of Streptococcus. Okay. If your pustular psoriasis becomes generalized and acute, we call that the generalized acute pustular psoriasis or the von Zumbusch. Okay, provoking factors include infections, irritating topical agents, like I told you, psoriasis has Kebner phenomenon, even withdrawal from oral corticosteroids. That's why we do not give oral corticosteroids to our psoriasis patients because withdrawal, yan. After discontinuing, malaki yung chance the patient would have your generalized pustular. It can be a life-threatening medical condition. That's why usually patients with this we admit in the hospital. Okay. Yan. There are symptoms of burning and pain. It can be accompanied by fever, malaise, and leukocytosis. Okay. And possible complications because of the severity of the condition, of the skin affectation, patients can have bacterial superinfection, sepsis, and dehydration. Same with this. This is another clinical manifestation but less common as well, your psoriatic erythroderma, meaning it already affects all body size, entire skin, at least 90%. Once we have at least 90%, that's called erythroderma. Okay? Still psoriasis, but erythema na yung more prominent, scaling becomes less. Okay? Compared to your chronic plaque psoriasis. And because 90% of the skin, remember your skin is the largest organ of your body, di ba? So if 90% is affected, they lose excessive heat because of the generalized vasodilatation and that can cause hypothermia. So our patients, nanginginig talaga sila, giniginaw kahit na wala na yung aircon. No? And complications would be high output cardiac failure, impaired hepatic and renal function. So like your generalized pustular psoriasis, we also admit patients with erythroderma. Okay, so I've already discussed Kebner and streptococcal infection that can cause guttate psoriasis. Stress can be a factor in flares, especially in adults, no? As high as 40% in adults can be triggered by stress. And some drugs mentioned earlier. Alcohol ingestion as well, no? Can be one of the trigger factors. So yung may mga psoriasis dyan, please do not drink alcohol. Do not smoke as well. Okay. Pathogenesis of psoriasis is alteration of the cell kinetics of keratinocytes with a shortening of the cell cycle, resulting in 28 times the normal production of epidermal cells. Okay. Your CD8 positive T cells, they are overwhelmingly madami, no? T cell population in these lesions. Okay. So the epidermis and dermis then react as an integrated system. So this is a T cell driven disease and the cytokine spectrum is that of the Th1 response. Okay. So this is important to know when in relation to our management, then we give biologicals, no? So, hindi ko na-update tong aking management. These are the old ones. We give this pa rin naman, ito pa rin naman yung mainstay, no? Yung emollients, we give salicylic acid to smoothen the skin. Coal tar no longer being given. UVB phototherapy we have in UARM. Calcipotriol, acetylene no longer available in the Philippines. We give also methotrexate and cyclosporin. Aside from your topical corticosteroid, topical lang ha. But recently or lately for the past few years, we already have the biologicals. So these are the injections, the injectables that addresses your specifically the pathomechanism for psoriasis. They are really good, no? So, some psoriasis patients no longer have flares, but it's quite expensive lang. Really a bit expensive. Okay. So we now go to Hansen's disease. Do you have any questions with regards to psoriasis? There's a question here. Doc, pwede po ba yung calcineurin inhibitors? Yes. Our first line, we give topical corticosteroids, usually the potent ones. But for steroid sparing, no, kasi we cannot give steroids for a long time because of the common side effects. So at the most, we give it for 2 weeks straight. To alternate with steroids, we give it topical calcineurin inhibitors, like your tacrolimus and pimecrolimus. Okay, regarding sebderm discussed earlier, is nitrile sufficient? Yes, can be sufficient depending on the severity of your seborrheic dermatitis. Scalp bruising from frequent scratching. Okay. Um, Nizoral care may not work if it's not being used properly. There has to be at least 5 minutes. For me, I tell my patients na ibabad muna ng 5 minutes bago nila banlawan. Secondly, if it's really paralytic, you can, Nizoral is your simply antifungal, no, to eliminate or to minimize yung malassezia for proliferation, di ba? But if it's really paralytic, you can give also corticosteroids. We have scalp preparation na corticosteroids. We can add that para hindi siya kumakamot, no? Can psoriasis first manifest in the hair? Yes. And there's also a condition I did not include in my lecture because it's not that common of pseudo-psoriasis. No, na it's a combination of seborrheic dermatitis or it's an overlap of your seborrheic dermatitis and psoriasis that's usually manifests in the hair. Okay. Pero there are cases na scalp psoriasis lang initially. Pwede yun. Initially, in the first few years, scalp psoriasis lang, and then eventually, eventually, magkaroon din siya ng generalized. Or, I mean, skin lesions. Okay, let me now go to Hansen's disease. Ay, ba yan? Mali. Wait. Okay. So, Hansen's disease, leprosy, yon, or ketong sa Tagalog, no? Okay, so this is a chronic granulomatous disease affecting the skin, peripheral nervous system, what time is it? Upper respiratory tract, eyes, and testes. So I have the last 20 minutes. So medyo bibilisan ko na lang, ha? It's not hereditary. It's caused by your Mycobacterium leprae. Transmission is nasal droplet infection or contact with infected soil and insect vectors, but not very common. Common transmission talaga is your nasal droplet infection. Okay. There's a clinical spectrum, no? It depends on the host capability to develop cell-mediated immunity to your Mycobacterium leprae. So therefore, the different types of your Hansen's would represent the spectra of the host immunologic response. Okay? So the host influences the clinical form of the disease whether you have strong cell-mediated immunity or weak humoral response. Okay, so pagka naman strong humoral response but relatively absent cell-mediated immunity, more severe. Mild form kapag strong yung cell-mediated immunity mo with a weak humoral response. I'll show you the pictures. Okay. Sige. Yan, ito muna tayo. The spectrum goes from tuberculoid leprosy or TT to lepromatous leprosy. Okay, so those with strong cell-mediated immunity, with weak humoral immunity, they have the tuberculoid leprosy. Meaning the organisms konti, hindi masyadong dumadami because they have strong cell-mediated immunity. Those with weak cell-mediated immunity, with more stronger humoral immunity, yun, dumadaming organisms. So these are the ones that present with lepromatous leprosy. Okay, so this is how they look like. Tuberculoid leprosy, okay. They present with few well-defined hypopigmented hypostatic macules with raised erythematous purple border enlarging peripherally. These lesions, they are anesthetic, walang pakiramdam. Devoid of skin appendages, walang hair, walang pawis, walang sweat glands, walang hair, walang pakiramdam, no? So, anhydrotic, anesthetic, and with no hair. Yan ang characteristic ng mga lesions na yan. Okay. Then, doon sa kabilang pole would be your lepromatous leprosy. So, here, symmetric na siya. Slightly erythematous papules, nodules on the earlobes, face, arms, buttocks, trunk, lower extremities. So, medyo madami na. And then, there's already loss of hair and leonin fascies kasi nag-deposit na yan sa mga, yan, puro teeming with bacteria na yan. Okay? So, no hair, wala siyang eyebrows. Okay, I discussed this earlier. Okay, remember, walang pakiramdam, so they have numbness. Sometimes it can appear first before skin lesions appear. And then the earliest thing that will patients lose is the sense of temperature. Yung cold and heat. Yun yung una nilang hindi maramdaman, no? That's the first thing that's lost, temperature. Next would be light touch, followed by pain and deep pressure. So we test first with temperature. Nararamdaman niyo po ba? We test them with cold water and heated water. Okay. So the treatment would depend if the person has a tuberculoid type of leprosy or lepromatous type of leprosy. Same naman yung gamot, except lang the length of treatment is 6 months for tuberculoid and 1 year for lepromatous. Okay. This is being given for free by WHO DOH. Okay. When there's already extensive nerve involvement, pwede kang may clawing of fingers and toes, chronic ulcers because they don't feel it eh. Tapos pag nasugat na sila, nag-infect na they don't know, no? So it can happen the sole of the foot, palms of hands and fingers. Okay. Once we give this medication, the patient would be non-infectious rather, within 1 to 2 weeks of treatment. So what are the diagnostic tests? We do slit skin smear. So this is a small skin incision is made and the site is scraped to obtain tissue fluid. And then, titingnan na yun kung ilang bacteria ang meron doon. So we get at least 6 areas. Meron both earlobes, that's 2 already, both elbows, so that's 4. Then we can get on the knee, one on the knee, both knees, or one on the knee and one from another active lesion. So smear is made and examined with Ziehl-Neelsen staining. Okay, so here's an example. There. Yan, pag maraming lesion, pwedeng Ziehl-Neelsen or acid-fast bacilli by 5-Farrakhan staining. This is a biopsy, but this is a slit skin smear. Okay. If there is no detection in the slit skin smear, no acid-fast bacilli detected. It's classified, this is the WHO classification, classified under posibacillary. And they receive only 6 months. So usually, these patients with posibacillary, they present as tuberculoid type. Nandun sila sa tuberculoid pole. Those with multibacillary category, so they detected yung acid-fast bacilli in the slit skin smear, they receive 12 months of multi-drug therapy. They are the ones that are usually on the lepromatous pole. Okay. And then, remember also that Hansen's disease treatment can lead to reactional states. Actually, kahit hindi treatment, it's a complication actually of your leprosy. No? These are immunologically mediated inflammatory states caused by the immune response against the antigen or your Mycobacterium leprae. No, it can occur spontaneously or after initiation of therapy, and there are two types: the reversal or the type 1, and the erythema nodosum leprosum or the type 2 leper reaction. What you have to know is in reversal or the type 1 leper reaction, there's acute worsening and inflammation of the skin lesion, and there's nerve function impairment. This is important because we have to be early in diagnosing this and treat them agad, the inflammatory reaction, to prevent a worsening of the nerve function impairment, no? Baka it might lead to paralysis or um, total, ang tawag dito, total anesthesia na hindi na babalik, no? Won't recover. So we have to treat that. And then your erythema nodosum leprosum presents as painful red skin nodules that are more palpable than visible. And it can also present with aggressive vasculitis with immune complex deposition affecting other organs like neuritis, panniculitis, your kidney, your joints, no? So it's very important to recognize them early as well. So patients with this type can have fever, edema, and malaise. Okay, so here, the painful red skin nodules become generalized, not lang dun sa initial lesion, compared with the reversal or type 1 reaction. Kung saan lang yung lesion, yun lang yung mamumula. Here, they have new painful red skin nodules that are generalized. Okay, I think I have last three conditions. Quick na lang. Pityriasis rosea. So this is a self-limiting, non-recurrent scaling maculopapular eruption among children and young adults. It clears spontaneously within 6 to 8 weeks. Nga lang matagal, no? But it can clear spontaneously. Okay. So how does it look like? Patients would present initially with a herald patch. So ito muna, like this one. Usually it's the one that's the biggest. It's a herald patch. It precedes the other lesions. In 2 to 3 weeks, probably mauna siya, no? And then eventually, after 2 to 3 weeks, more lesions would appear that may cover the entire trunk, upper thighs, and arms. Characteristics of the lesion is color red scaling. The scaling is just on the borders, not the whole lesion. Kaya we call that the color red scaling. And then the lesions also, once dumami na sila, these are reddish-brown, discrete macules that follow the lines of ribs in a linear fashion, no? Parang, the, sorry, the lines of cleavage of the skin. Kaya sometimes it's called the Christmas tree pattern. Wala ba akong picture on the back? Ay, wala. Sorry. I think I removed the picture. Better to see, look for pictures na meron sa back. It looks like a Christmas tree because it follows the lines of cleavage on the back. Okay. Management, antihistamines, soothing lotions, reassurance as the lesions naman would resolve. However, it will take 6 to 8 weeks before resolution. Okay, let me just go through urticaria, scabies, and superficial fungal infection. Okay, urticaria is a cutaneous reaction pattern to infection, drugs, food, parasites, physical exertion, or solar exposure. So, it will present with wheals, or ito yung tinatawag din na hives, no? In layman's term. Okay? What's important for you to know, it's very periodic, it is transient, and it will disappear within 24 hours, then new lesions will develop again. So that's why it's called evanescent. Okay, it will disappear within 24 hours, then new lesions will develop. We have two types, the acute and chronic. Chronic condition, the acute when it happens within less than 6 weeks. But if it happens more than 6 weeks, it's a chronic condition, and this time, pag we get patients with chronic urticaria, we investigate na for possible reasons. Most probably, it's not due to food. It can be due to some infection, no? Kaya siya mentioned chronic urticaria. Okay. Next is your scabies. I believe this is already discussed by Dr. Yang in your infection and infestation lecture. So you know how it looks like. Pruritic papules and vesicle or pustule. Clinic usual areas is your circle of Hebra or the imaginary circle intersecting the main sites of predilection. The treatment, permethrin, no, that's a treatment. What you have to remember is that we have to treat all household and sexual contacts, the house also change and launder clothing, bedridden. And then sometimes, even after successful treatment, you can still expect itching for 1 to 2 more weeks. No? Kahit na nag-permethrin na. So, you assume na matay na si Sarcoptes kba because of the permethrin, but they're still itching. And this happens due to the hypersensitivity reaction to the dead mites. So, it doesn't mean that you have to treat again with permethrin, but you just now have to treat the hypersensitivity reaction. Okay. Next, for the superficial fungal infection, I think this was also discussed by Dr. Yang, no? Just remember that we have three fungi that can cause your superficial cutaneous fungal infection, the fungal species, the candidal, the dermatophyte infections, and your pityriasis versicolor or tinea. Okay, the candidal, okay, I can skip that na. Okay, it can present as candidal intertrigo. And don't worry, the ones that I'm skipping, I did not include naman in the exam. So, as I told you earlier, if you listen carefully to my exam, you'll be able to answer the questions that I gave. Okay. And the candidal paronychia. The dermatophytes, these are the superficial, again, superficial din naman siya. Caused naman by filamentous fungi. Your candida is mold, di ba? This one, or yeast rather, sorry. This one naman is caused by filamentous fungi, which are produced by spore formation. So here we call that the tinea. Yung mga sakit na to, ito yung mga buni. Buni, hadhad, alipungan. Ito siya. Um, in English or medical term, it's the tinea followed by the body side. So it can be tinea capitis, tinea manum. So here. If you have on the head, it's tinea capitis. If you have on the body, it's tinea corporis. If you have on the nails, it's tinea unguium or onychomycosis. If you have on the feet, tinea pedis. In the inguinal area, it's tinea cruris. On the hand, tinea manum. On the beard or on the face, tinea barbae or tinea faciale. But in essence, it's all the same three causative agents, either your trichophyton or your epidermophyton or your microsporum species. And mode of transmission is direct contact from humans or domestic animals. Okay. Lastly, we have the tinea versicolor or pityriasis versicolor. So this is naman your an-an. No, I'm sure you've heard of that. No, this is persistent, usually symptomatic fungal infection of the trunk, the chest, the back, the upper arms. Sometimes the face, sometimes the thigh, the abdomen. Okay. It's caused by your Malassezia furfur. Okay, it's very common in the Philippines because of our tropical humid weather. Okay, so we see hyphae and yeast in skin scrapings stained with PAS. So we call this pattern the spaghetti and meatball. So we get the flakes or the scales rather, no? The thin scales. We do KOH. Pag biopsy PAS, but this is KOH, potassium hydroxide stain. And then you see here spaghetti and meatballs. Yan, so this is how your an-an would look like. It's versicolor, so actually hindi naman kasi siya always puti. Akala kasi ng Pinoy laging puti. Parang, doktor, hindi naman po an-an yan kasi pinkish, no? It can be whitish or hypopigmented like this. It can be pinkish or erythematous like this one. It can even be dark or hyperpigmented, especially dark-colored Filipinos, no? That's why it's versicolor. It can be any of those three colors. Okay, so those are my references. You can read Atlas and Andrews, and thank you. Yeah, so do you have any questions for me? Sige, sa chat. Mm. Same po ba, yung clinical presentation of chronic ulcers by Hansen's and diabetic foot? Yes, in essence, they are both neuropathic ulcers, diba? Yeah, kaya ka nagkakaroon ng foot ulcers with Hansen's kasi wala ng sensation. Same with diabetic foot. If your patient already has diabetic neuropathy, and then may decreased sensation na din sa foot, nagkaka-ulcer, same presentation siya. Mm. Which one yung an-an? Tinea versicolor. No, an is just tinea versicolor. Ngayon yung other tinea, like tinea corporis, that's your bony. Tinea pedis, that's your alipunga. Ano ba iba? Hadhad is your tinea cruris or jock itch. Yun lang yata yung mga Tagalog terms. Yeah. Mm-mm. And you should also be familiar with the Tagalog terms because when you go to clerkship, yun yung naintindihan din ng mga pasyente. Hansen's is your leprosy or ketong. Okay. But not all condition have Tagalog terms kasi. Any more questions before we end? It's 2 to 10. Nakakahawa po ba yung an-an? Okay, in theory, hindi. Because remember, your Malassezia furfur, your Malassezia, what's the causative agent of an-an? It's Malassezia. All of us, we have Malassezia furfur in our skin. Okay? It's just that some people, because of the humid weather, probably they're also so sweaty, no? Mas nagiging active, more active yung Malassezia furfur sa kanila. That's why it's a recurrent thing among those patients. Okay, so in theory, hindi talaga siya dapat nakakahawa. Hmm. Kasi you have that same, same fungi on your skin. Okay, let me end my sharing. Any questions pa? If none, good luck in your exam. Not all of the questions come from me, ha? So, but if you listen to my lecture, at least the questions that came from me, I already discussed. You'll know the answer. Okay. Thank you. Thank you, everyone.